So when we think about personalized medicine, there's been a lot of effort over the years to really find what's best for each person, to create the trials, to study the patients, to study the therapies and the diagnostic tests that get us to those therapies. And we try to encapsulate and compile all of that into guidelines, into pathways. And so it's really important that we give, proper respect and attention to those pathways, because those really are the best routes to the best outcomes for the patient. It's really important to get them on the right path by first testing correctly, as recommended, and then secondly, based upon the results of that testing, to get them to the appropriate targeted therapies.
The value of following a pathway or a discrete set of guidelines really comes from the fact that at the point of decision, you're receiving clinical decision support backed by evidence, and you receive the benefit of others' research to know that your patient is getting the best care. This is not, I'm telling you to do this type of an environment. This is, I'm your helpline. I'm giving you the support you need based on the evidence of others.
A lot of folks think that it's going to be very expensive, but I would object and really put forth the notion that it's a way really to streamline your path, weed out everything else that's a distraction, that's costly, and then although there may be that upfront cost of the expensive test, for example, to get you on the right path, in the end that will save money, because you just avoid all the other unnecessary tests and treatments that really won't work.
I really see three barriers to the implementation of effective pathways to allow patients to get the most appropriate genomic informed personalized medicine today. The first barrier is that the majority of the oncology community trained in the pre-genomic era. They're in a heterogeneous set of care environments, some with a lot of daily and weekly reinforcement, others who we have to just thank them for being in existence, because if they weren't, patients wouldn't get care. The second barrier is that the technology infrastructure and the workflows that oncologists are working in today aren't necessarily helpful. And so the workflow environment is probably a big impediment to getting the right testing done for the right therapy. The third impediment is the payer environment, whereby the messages being received by oncologists, particularly from the commercial insurance companies, is not necessarily reinforcing to do the appropriate genomic testing for the appropriate therapy.
If one patient has lung cancer, their cancer is molecularly different than any other patient. So truly an N of one, right? So why should one patient get the same treatment as the next one, the next one, the next one? Now with this information at our fingertips, we can deliver true personalized precision medicine. So the standard of care becomes do NGS on all cancer patients, and then a level of combination recommendations to say, for this patient's specific cancer, this is what we're going to do. And so the standard of care becomes more the steps to take before drugs are administered, not just patient has lung cancer, here are the drugs for lung cancer.
Increasingly, there's this concept of value-based care, and I think that health payers in particular are increasingly being reimbursed and reimbursing on that basis. It's so wonderful that we have this opportunity in a forum, say through the Association for Value-Based Cancer Care, to really discuss and come together all the different players to talk about how we can improve cancer care for the most important party, the true stakeholder, the patient, him or herself.